Assalamu alaikum. Hello and welcome to this second webinar in the Pain Management for Patients series, supported by SSMC and SAHA and supported by Pfizer Upjohn. The date is September 9th, 2020, and the time is 7 p.m. here in the UAE. My name is Gerard Moore, and I am the Technical Support Manager. So if you have any technical issues, you can press the red Reconnect button at the top of your screen. That will automatically resync your video. Or you can send me a private question to the admin only button. That will come directly to me, and I will answer your questions directly and privately. The chat bar is open and is welcoming all scientific questions and comments for our speaker and chair today. I will now hand you over to Dr. Ahmed Shatila for the official opening of the webinar. Dr. Ahmed.
Thank you, Gerard. First of all, good evening, everyone. Thank you for attending. There we go. Thank you for attending the second webinar on neuropathies. Today we're going to be talking about diabetic neuropathies, and I would like first of all to thank our sponsors, Pfizer and Upjohn, for sponsoring this event. I would like to thank SSMC for hosting the event, and finally I'd like to thank everyone who actually showed interest to attend this event, because without you we couldn't have these webinars. Today I would like to introduce Dr. Ossama Barakat. He is a consultant physician and diabetologist at the Imperial College of London, Abu Dhabi, and he is going to talk today about diabetic neuropathies and foot complications. So without further ado, the floor is yours, Dr. Ossama. Thank you very much.
Thank you so much, Dr. Ahmed, and good evening, everyone. And may I just really re-thank everybody who stood behind this event. I would hope that we spend the next probably 20-25 minutes trying to get the best out of the subject, really, of diabetic neuropathy. I think before we dig into the talk, I would like to say that this talk really will concentrate mainly on trying to get a bit of understanding about what diabetic neuropathy means and how do we get to recognize it and trying to prevent it. We will not be talking about medical and pharmacological drug therapy for diabetic neuropathy, because we're trying to get into a more of a general knowledge about the subject, which is really quite interesting for the majority of us. So I think you're all aware of the term diabetic foot. I think for us to understand the term diabetic neuropathy, we have to understand diabetic neuropathy isn't really just foot problem in diabetes. Now, you all, and I'm sure you're all aware that diabetes does affect our blood vessels. So when it affects the large vessels, that's what we call a macro vessel disease or complication. So when people get heart attack or stroke or mini stroke, that's really related to large vessels. Now, when diabetes does affect your small vessel or small vessels, that's what we call microvascular or micro or small vessel complication from diabetes. That affects the eye, we call it retinopathy, affects the kidney, we call it nephropathy. It may advance to kidney disease, advanced kidney disease. And then when it affects the nerve, then we call it diabetic neuropathy. Now, we all know that nerves exist everywhere, from up to your brain down to your toes. So the term diabetic neuropathy isn't just diabetic foot, but it may present primarily as just numbness in the foot. And for us to understand diabetic neuropathy, we really need to understand how it happens and why it happens. So at least we're able to treat it. I must emphasize that the photos we see nowadays haven't really changed over the last 20 years. We still get very mild complication like small ulcers to an advanced complication like amputation. But really, the mechanism of the disease is what really matters to us, physician and patient. So for us to understand it, we're really going to refer to three terms. So it's microvascular, that's M, it's metabolic, that's the disease, and it's hypoxia, lack of oxygen. So what happens in diabetes really, any tissue in the body, including the nerves, will need a blood supply to live and survive. So when you have small vessel being affected by diabetes, where the vessel wall gets thickened and you get less blood supply to the nerve, this is when you get the first problem. In addition to this, diabetes by itself, so the metabolic part of diabetes, if you have high glucose, that tend to turn your immune system sometime against your own nerves. And we get the term, you probably hear it, autonomic dysfunction, which may affect your stomach. You start feeling sick, get a bit of diarrhea, it may affect your feet where you lose sensation. In men, it may cause a bit of erectile dysfunction. So that's another way of getting the nerve damage. The other way of getting the nerve damage is the sugar itself. When it goes to the nerve fiber, the nerve fiber it has cells, and those cells have a surface. Once the glucose gets into the surface of these nerve fiber cells, it makes them balloon because glucose will attract water. So when the glucose gets into the cell, there's more water getting into the cell, and they become swollen and dysfunction. So it's a three-way of getting the nerve issue in diabetes. Number one is the lack of blood supply and lack of oxygenation, which is hypoxia. Next one is the increased glucose, which in the body, which may turn your immune system against your own nervous system. Thirdly is when your glucose is high, you get dysfunction and swollen cells, and which may affect the nerve fiber eventually. So it's a kind of complicated mechanism, but that what really matters. So if you really want to solve the problem, well, what you have to do is you make sure that you have a very good blood supply, you control your blood sugar, and you control your weight and your cholesterol and your blood pressure, and you stop smoking, because all of this will improve your microvascular blood supply, will improve the oxygenation in your body, and reduce your blood sugar. So now we know the mechanism, we know how to treat it and really prevent it. Now, is it very common? Let me give you another. I mean, those figures are there. I can tell you that around 50% of patients with diabetes at some stage will get some kind of nerve problem or neuropathy. It may vary in its presentation. It may be just numbness and no pain at all, just a bit of tingling sensation, to the other extreme of amputation. But in general, I would say probably 50% of those patients will get some form of neuropathy. Around 25% of those people will get just no pain. 30 to 40% of those patients will really get painful neuropathy, and maybe a third of them will get erectile dysfunction if they were in the men part. So it's very common, bearing the fact that actually diabetes is very common, and we know it's only a matter of time before we get probably over 700 million diabetic patients. And you have to remember, for each one diagnosed patient, we probably have 3 to 4 undiagnosed patients with hidden diabetes. Does it occupy a lot of our work in hospitals? With diabetic patients in general, they make about half of all hospital admission for amputation. It is very, very high prevalence. And the lifetime risk for foot ulcer until recently was generally believed to be around 15 to 25%. But actually data suggests that it is as high as 35 or 34%. Even in the UK, people with diabetes, they account around 40% of hospital admission and major admission for amputation. Around 70% of emergency room admission. Not even just neuropathy. I mean, hypoglycemia by itself, low sugar, does occupy a lot of UK hospital work and emergency room admission. So diabetes, it doesn't just come with hypoglycemia or high sugar. It comes with multiple complications. And neuropathy, or the other spectrum of amputation and foot ulcers, is the other part of the admission. It's very important to know that actually diabetics are 20 more times likely to be hospitalized for non-traumatic limb amputation. You can see the data for yourself here. Lower limb amputation are much higher in diabetic patients, and that carries a risk of psychological barrier on the patient, a lot of economical burden on the health system, both in hospital and outside hospital, in addition to the stress that the patient and the family will encounter eventually, because some of these people have to be rehabilitated in terms of physical activity and even psychological trauma after amputation. So it could be very, very nasty. Now, the term, and you will hear it a lot, diabetic peripheral neuropathy is really the primary risk factor for getting into foot ulcer. What does that mean? It means once you start getting numbness or altered sensation in your foot, this is the time where you be actually not be able to recognize a lot of differences between heat and cold, pain, no pain. Because at that time, when you start to have altered sensation in your foot, this is where the problem may start. You may start with a small ulcer, you don't feel it, you're late, you go to the hospital, it's a bigger ulcer, it's infected, and so on. So really, the presence of symptoms and signs of peripheral nerve dysfunction in people with diabetes is very, very crucial. Once your patient says, I have numbness in my feet, you really have to take it very seriously. Now, you may not find anything serious, but at least you keep it in your documentation, at the back of your mind, in your patient history, that this patient does have altered sensation in his feet. But certainly, a good care should include really excluding other causes for this numbness in the foot. We talked about the pathophysiology and how you get diabetic polyneuropathy. I'm not going to dig into this in details. Now, the pathway of diabetic foot ulceration, I'm so sorry. As I mentioned to you before, all what you have to have is a bit of numbness, altered sensation, then you start to have a bit of callus formation or a bit of hard skin underneath your foot. Later on, the patient might bleed into this without even thinking that he may have something, because majority of them at that time would have lost sensation, eventually lead into a foot ulcer. So you start from numbness, hard skin, bit of blood underneath the hard skin, opens up, and then you get the ulcer. Very easy, but it's very nasty when it's happened unless you catch it and treat it properly. So how do patients present with diabetic peripheral neuropathy? It's very important both for patient and doctors. And you have patient with subjective symptoms, and they say to you, doctor, I have numbness in my feet. I have a bit of burning sensation, right? And some people may present with nothing, just no symptoms, no pain. And those are the people you really have to pick up on clinical examination. This is why it's very important that we examine the feet of diabetic patient on a regular basis. And as mentioned to you before, half of the patient normally present with burning sensation, and the other half may present with no symptoms at all. So the major question is, does the patient have neuropathy or not? I think once a diabetic patient or even a pre-diabetic patient raises suspicion of altered sensation in his feet or in his hands, that has to be considered diabetic neuropathy till proven otherwise. We know that B12 deficiency may cause this, anemia, vitamin D deficiency, spinal collapse, disc prolapse, you name it, some medication, chemotherapy, and so on. All of this may cause a bit of neuropathy-like sensation. But once the patient presents with symptoms, you really have to confirm it till proven otherwise. Now, how do we deal with this in the clinic? Normally, as you do in life, as you do in medicine, as you do in your life in general and any other work, is you actually risk categorize those patients. So you go from low risk when the patient have normal sensation, and I'll show you how to examine the patient later. Moderate risk when the patient had a bit of loss of sensation, and you go to the high risk and very high risk, depending whether the patient had an ulcer or not, or they had an amputation. So certainly somebody with a history of ulcer, amputation, and or neuropathic fracture or neuropathic pain, then those are considered as a very high risk. Patient with normal sensation is a low risk. A low risk should be followed every 12 months. A moderate to high risk should be seen every 3-6 months and examined. A very high risk probably should be seen every 2 to 4 weeks, especially if they have active or non-healing ulcers. So the International Diabetes Federation urges all healthcare practitioners, and I mean everybody who is involved with diabetes, to treat patient early in the window of presentation. Do not let go once you see a sign of auto sensation. And you may just have to tell the patient, look, you have to get your diabetes much better, and maybe you have to change your footwear. As simple as this. If they have a bit of hard skin, that has to be cleaned and looked at. And if they have painful neuropathy, then has to be treated, and the blood sugar has to be well controlled. So how do we do a foot screening for peripheral neuropathy? So you have, as you know, your nerve does a lot of things. One of them is the touch pressure sensation. The vibration is like, you know, the whizzing in your ear. And then we can measure the vibration perception. That's a different electrical machine. Temperature sensation is very important. Pain sensation. And for doctors and nurses is to check for refluxes. So your nerve does touch, does vibration, does temperature, does pain, and does refluxes. Very clever, small tissue in your body. So patient and doctors, you all probably at some stage had used or have been examined using the monofilament. The way to use the monofilament is using a 10-gram monofilament, really to look at areas at the plant of the bottom of your feet, to look at really the pressure sensation. So you hold it there for 10 seconds, make sure the patient closes the eyes. It's a 10-gram monofilament. Can you feel it, yes or not? And you have to do it preferably at least in 3 points in each foot. The other way of doing it is really check for vibration. As you're all aware, the same vibration tools that we use to test hearing, we can use it for vibration sensation over the big toe. If the patient can't feel the vibration of the vibrating tool, then the patient really has lost sensation. And you can do it in both big toes, and at the same time, you really have to leave it 10 to 15 seconds to allow the patient with their eyes closed to feel the vibration sensation. Now, the measurement of vibration perception threshold, not very used commonly. That depends on a bit of electrical, certain voltage of electricity. We don't use it. It's an old machine, but maybe in more advanced places they still use it. Especially nowadays with a large number of patients, short time, we tend to use the monofilament and the vibrating tool. Now, another clever way of measuring is to check for temperature. And this is very clever pen that gives you a bit of cold end. They can just make sure the patient with the eye open on the hand or forehead, make sure they can feel it, and they can feel the cold end and the warm end. You ask them to close the eyes and put it at the back of the foot or even the bottom of the foot and say, can you feel cold? And is it cold or hot? Bit tricky if the patient hasn't done it before, but it gives you at least, temperature sensation assessment. And sometimes you may get false positive results. Probably it means that, the physician hasn't used it before and the patient is not used to it, and you may get a bit of confusion over the results. The standard really for us remained is the monofilament. The first one I've showed you is the 10-gram monofilament. And then we have in the clinic, we have something called a pain assessment score. And really that goes from, mild pain, moderate to severe. Really that's just assessment of the symptoms, how severe the pain is when they have painful neuropathy. And, then you can assess. And people think, well, the higher the pain, the worse it is. Actually, if patients don't feel the pain, this is where the problems start. But that's, again, a score that we don't use it quite a lot. We either say, painless neuropathy or painful neuropathy. That's the difference we make in our clinical notes and clinical judgment. Checking for refluxes for ankle jerk. I'm sure the majority of the doctors, even patient nurses, seen this. Now, but you have to remember, people may lose their ankle jerk as they get older. If they have other diseases, have a spine problem, even hypothyroid and underactive thyroid may cause you to lose your ankle refluxes. But it's nice to know if you have suspicion of neuropathy, whether your patient can or cannot get an ankle refluxes response. So When we look at the treatment for diabetic neuropathy, we talked about the pathophysiology or the mechanism of diabetic neuropathy. Number one is you have to correct your blood sugar. You will not get a control unless you control your blood sugar. Your neuropathy will never get away or go away unless you control your blood sugar. Then there's other things that you have to improve. So when you talk about lack of blood supply, sometimes we use aspirin or other antiplatelet. We control the thickening of the wall of the blood vessels. We use statin and cholesterol tablet. We control the blood pressure to allow better blood flow to certain places in the body. And we may just have to use a proper footwear. And there's other ways that we're not going to go through it now, because the goal of this talk is really not to get into more complicated therapy. So it's actually controlling your blood sugar is what matters, controlling your blood pressure, controlling your cholesterol, a proper footwear, regular examination, and specifically no smoking and reduced alcohol intake. You really have to have a healthy lifestyle in order to do this. And this is really the pathway for diabetic foot ulceration. You can start with just numbness, may get into small ulcer, may get into infected bone under this ulcer, may get into deformity, fractures, different color of the skin, dark skin, bit of erythema and redness, and it may end up with non-healing or a long-standing foot ulcer. So the pathway for diabetic foot ulceration is really, really wide. So foot care checklist is you need to educate about the foot care. We need to examine as physician, both for the shape of the foot, the blood supply, the sensation. We have to use the 10-gram monofilament assessment, trying to assess patient risk, old people, poor control, smoker, obese, previous ulcers, previous amputation, and refer the person with foot ulcer as early as you can to specialized center with foot care. So early referral, but before this, early awareness. Screening for foot complication. Again, we have what we call the Wi-Fi system, where we assess the degree of tissue loss, so the wound severity of ischemia, meaning the lack of blood supply, and severity of the foot infection. Make sure there's no nasty pus coming out, bad smell. So it's the Wi-Fi system. It's the wound severity, the ischemia, then the foot infection. This is the American Diabetes Association foot risk classification, and that's, I think, important for healthcare professionals, that who to refer, when to refer. We go from very low category to very high risk category. Low risk, just monitor. Very high risk is active and urgent referral to the specialist care. Prevention through education is what matters. Proper risk assessment, early and aggressive treatment is what we want to be doing. Those are the things we should do. Is you check your feet every day, you look at the mirror, look at the color of the skin, change your socks every day as a patient, look at your nail, make sure you cut them properly, make sure that you clean your foot properly, and make sure it's dry before you put your shoes on. The don't is really don't ignore cones and colors. Ingrowing nails are very important. Do not apply heat with hot water. A lot of patients do this in the winter. Do not soak your feet or use lotion between your toes, because it may make easy place for fungal infection. Don't take very hot baths. Do not walk barefoot as diabetic. It's a don't, and don't. Tight socks, elastic socks. Do not smoke. Those are really the healthy stuff we should be doing as patients. We talked about how to perform a foot examination for a physician. So look at the foot, check for the nerve, and check for the artery or for the blood supply. So it's eye, blood, and nerve. Those are the key elements for our extremity physical examination. Again, is to look, to feel, and check and look at the footwear of the patient. And really, this is important for doctor. Who are the high-risk patients? People with neuropathy, previous amputation or ulcer, people have deformity in the foot, people who have major blood vessel problem in the heart or even in the legs, people with eye and kidney disease, people with high sugar, and people with a previous fungal infection. We talked about how often should we examine: low risk every year, high risk more often, every 3 to 6 months. People with foot ulcer, you may have to see it every 2 to 4 weeks. Again, even for the foot ulcer, there's an intraprofessional team approach where we can say those are a high risk for ulcer. And if the ulcer develop, what do you do? So people with a high risk for ulcer is we educate them about foot care, and then we try and put proper professionally fitted footwear so they don't get the ulcer. But once they get the ulcer, is to be referred directly into the specialized team. Those are the recommendation for healthcare provider. Really look for neuropathy, skin change. We talked about this. Structural changes, just really repetition of the awareness. The recommendation number 2 is to early refer, and people with diabetes who get foot ulcer or show any signs of infection, you must treat promptly. And if you don't know, if you're not quite sure, just refer to the specialized center. Recommendation number 4, sometimes debridement of dead skin colors may prevent the presence or the actually formation of an ulcer. But again, that has to be done with a podiatrist and a foot care specialist or physician. Recommendation number 5, probably there's insufficient evidence to use these topical cream and silver padding and dressing. So those are really gray area. We recommend people do not use it unless they have experience and they have really a good cover both medically and institutional to use those pads and on these wounds. The key message really, in person with diabetes, low extremity complication are a major cause of morbidity and mortality. The treatment of foot ulcer in people who have diabetes requires intraprofessional approach. Antibiotic therapy is not always required and recommended, sometimes topical therapy or just debridement. Priority advanced wound dressing and technology, including antibacterial dressing, really lack any evidence, or probably we don't have enough data for us to use them. So it's awareness, prevention, and early referral is what matters. And thank you very much for listening to me. Thank you.
Thank you, Dr. Ossama, for the excellent presentation. شكرا كثير.
شكرا لك.
Very educational. طيب أنا عندي سؤال. I'll start off. بلش الأسئلة. طيب أنت حكيت إنه in your presentation إنه العوارض or complications من الدايابيتس. يعني إذا واحد عنده السكر، يعني هالأشياء اللي حكيت مضمونين يصيروا ولا how do you prevent it? I mean, إنه if I have diabetes, am I going to get amputation? Am I going to get a neuropathy? Or is it preventable? فينا نمنع هالأشياء.
Very good question. I always say to people nowadays, look, those nasty photos that you see about, amputation and stuff like that, we hardly see it nowadays, especially specifically in places like UAE. The level of awareness has increased quite a lot over the last years for patients and doctors. So not every diabetic patient will get amputation. That will never happen. Probably I would say 40% of the patient will get some ortho sensation in the feet, especially with a long duration of diabetes. Okay? Everything is preventable. Now, we know from the scientific data that even if you do have microvascular complication like eye and kidney, by improving your A1C, if you drop your A1C from 8 to 7, you're actually going to prevent the incidence of those things by 30 to 35%. So if you have an A1C of 8, you bring it down to 7 in a nice way. Actually, even the microaneurysm in the eye, it may disappear. Protein in the urine, it will go. So everything is preventable, okay? And sometimes if you had diabetes for 30 years, 35 years, even with a good control, you may end up with a small ulcer or may have a problem with your toes, right? But that's very rare. So in answer to your question, they're very preventable, and not everybody will get those complications. And some people are genetically protected. They get diabetes for 50 years without any eye problem or kidney problem, right? But certainly with good control.
Thank you, shukran. عندي بعد سؤال before قبل ما نبلش مع الأودينس، إنه مثل ما بتعرف بالخليج العربي people like wearing النعال, sandals. And then I always tell my patients, دايما بقول my patients that they're إنه it's dangerous, it's not healthy for them، خصوصا إذا عندهم diabetes، لأن يمكن يكون في بحثة صغيرة حجرة أزازة ومعقول يجرحوا حالهم. أو شو بتقول يعني شو بتنصح للعالم اللي that like wearing sandals? It's part of the culture.
For me, actually, I have to say, because working in UK for 30 years and then coming to the Gulf, they are blessed to be wearing this for majority of the patient, right? Because they actually can inspect more often.
Okay.
Right? So in places like shopping centers, clinics, their houses, okay, that's fine. Supermarket. But when you start getting into outdoors, desert, and whatever activities you do, and driving, you probably shouldn't be wearing those sandals, right?
Okay.
And you can see nowadays better understanding in the Gulf. People start to use those lightweight sport shoes, right? Where they actually walk in, especially in the winter, because they're having to wear socks and stuff like this. But if you go into specifically clean places like the shopping center in UAE, hospitals, visiting your family, indoors, then that's fine. But otherwise, you're quite right, it's dangerous. In Europe, the inspection of the foot is pretty much impossible because of the cold weather.
Okay.
Plus, they don't wear sandals in the summer, very rarely. So I think it's very good and sometimes could be dangerous, as you said.
شكرا كتير. Thank you. So, Gerard, there's a lot of questions we have. I can start asking, or you have probably they were sent to you, so why don't we start?
Yes, thank you very much. There are some private questions that we've received, Dr. Ossama. Thank you very much for an excellent presentation. A gentleman has wrote in saying his father has diabetic neuropathy. He is high risk, but he does not want to amputate. Is there anything he can do in his lifestyle to help him prevent or combat at this late stage?
Well, if he's listed or been advised to have an amputation, okay, then there's a very good reason that he should probably comply with his physician, right? And Dr. Ahmed knows much better than me that sometimes you may have dry gangrene. So if you get to a degree of gangrene, sometimes you may have those dry gangrene, especially in elderly patients, at the tip of the toe, and those normally could stay there for months and years, or they may just auto-amputate by themselves. So I don't think that if you need an amputation, there's a lot you can do apart just following the medical advice, okay? But if you really been told your risk of amputation, right, is high, then really is controlling your blood sugar, stopping smoking, and proper footwear and regular follow-up with your physician.
So, thank you.
الوقاية تلتين العلاج مثل ما بيقولوا.
Exactly.
Another private question we received is that the patient is not diabetic, but they do have other symptoms, hard skin and bleeding. What should they do immediately to help cure that, or should they go straight to see a doctor? What do you advise?
I think to be honest, they need to see the primary physician, do at least an inspection by a doctor, have basic blood tests, and to do at least a diagnosis with the physician. They need some kind of assessment. It's very difficult to advise just to do nothing or do all of this.
Yeah, understood. I think a follow-up question to that from a different person asked: Are there any easy tests that they can do at their house, at their home themselves, to test if they have it or not?
Absolutely, try not to do anything at home. Absolutely nothing. Okay, you have patients trying to test for heat, where they put the feet in the hot water and they end up with burn, right? Some people in Europe try to put the feet on the heater. They end up with third degree burns. Do not try it at home. Look, if you live in UAE, you are blessed. You can get advice within seconds from anywhere.
There are a lot of centers that take care of patients with diabetes.
Don't even risk it. Don't even risk
Excellent centers. مظبوط.
Okay. A patient has wrote in again along maybe similar lines. She says she has numbness in a couple of toes, which have had nerve conduction tests done on it. They are not diabetic nor pre-diabetic. Is numbness common without diabetic neuropathy, or have I not given the diagnosis yet?
That's for Dr. Ahmed to answer.
So the question is, إنه في numbness في تنميل, she doesn't have diabetes. Is it common? نعم, you can. I mean, diabetes is just one cause of neuropathy. There's multiple other causes. في عدة أسباب لتنميل الإجرين غير diabetes. So you can have neuropathy and have diabetes, but you can have neuropathy from a million other things. And that's why you need to see a neurologist to figure out what it could be. B12 deficiency can do it. Some heavy metals can do it. Infections can do it. There are a lot of causes of neuropathy, and diabetes is only one of them. So you need to see a doctor.
The most common cause for obesity, for neuropathy in the gut is actually obesity. You'd be very surprised. Extra weight.
Next question. I believe this is coming from a healthcare professional. They're asking, does metformin-induced B12 deficiency have any relationship to diabetic neuropathy?
That's a very, very clever question. Look, we didn't know up until recently. Look, metformin by far is the best medicine we've had since 1958. So no question about it. It's very safe even in pregnancy and in children. So let's just put this on one side. It may increase the risk of anemia, and specifically B12 deficiency anemia, okay? But that's in very rare cases. I would say we probably see it in 5 to 7% of the cases. And therefore, instead of sacrificing metformin, what we do, and that's a recommendation now from the ADA and IDF and WHO, is to measure your B12 annually as a diabetic patient, full stop. Now, if you see somebody with B12 deficiency quite early in the disease, so they haven't been on metformin for a long time, then you really have to look for other causes of B12 deficiency, okay? Like atrophic gastritis, Helicobacter, celiac disease, malabsorption, or pernicious anemia, okay? But if you have somebody had diabetes for 20 years, been on metformin for 20 years, the most likely cause of B12 deficiency is metformin. Okay, but that's, as I mentioned to you, probably 5% of the patient we have. And therefore, what you do is do not stop your metformin, just give the patient B12. End of the story.
Thank you. Thank you. We've also received a number of questions with regards to medications, and of course, as Dr. Ossama mentioned at the start, this webinar is focusing more on the holistic aspects, the lifestyle aspects of diabetic neuropathy. But if you do have any questions, I'm sure you can consult your physician about those. Next question is a very general one. Said, in case they are experiencing pain, what should they do? What the first steps which they should take when they start encountering pain for the first time?
See your doctor. Simple as this.
Always. And I would say also, Gerard, in regards to people who have questions about diabetic neuropathy and pain, we do have a large number of medications that we can try as physicians to help relieve it. And that's why it's important to go follow up with your physician, because the purpose of this talk today is to educate people about diabetic neuropathy so they can recognize their symptoms, or if they have a loved one with it, so that they can also go to the physician. There are medications that can greatly help the pain and reduce the pain and make these people have an active lifestyle. But that's a conversation between you and your healthcare provider.
True.
Thank you. Another question here is what level of HB1C is recommended to prevent neuropathy?
Okay, that's very clever and very broad question. Now, I always say to people when I give talks, you may see 20 diabetic patients per day. Each one of them will go out with different bag of medication. Each one of them should have or might need a different A1C. Now, the general rule of thumb is you need to have an A1C. If you have a good life expectancy, above 10 years life expectancy, if you fit and well, you should have your A1C, say, between 6 and 6.5. Okay, it's more acceptable if you're, you get older, that probably 7% is okay. Now, the American College of Geriatric Medicine does recommend that if you have elderly patient above the age of 70, 75 with good quality of life, then they can 8% is okay. So each patient needs a different A1C, okay? But generally, we should keep an A1C, I would say, between 6.5 to 7% in general, but that doesn't apply in older people and people with other problems. I would say to people, you would drive your car in different speed when you're 80, right? You can drive faster when you're 40 because you don't have an accident. So if I push you with a strict A1C when you're 80 and you get low sugar and you fall and you break your hip, then you're done, right? So A1C, we don't actually rely on A1C quite a lot nowadays. It's the patient in front of you, what's the fasting blood sugar, what's the sugar after food, okay? And what's the average A1C needed for this guy? What are the complications alongside diabetes? How old is the patient? How long have they had diabetes for? Okay, you cannot ask somebody who's 40, who's blind from diabetes. That doesn't happen nowadays, right? To have an A1C of 6%.
Okay. Thank you. There is a question here. It's more of a comment from Tariq Al-Afifi, and he says that microfilaments is for light touch. It's not very practical because testing light touch, which can be carried by both small and large fibers, and he feels that spinal thalamic, because they're carried by spinal thalamic tracts, temperature and vibration, he feels could be more accurate.
Oh yes, he's quite right. But I mean, look, for people who have normal skin and no colors and do not have neuropathy and a lot of other sensation, the monofilament is probably the easiest. Okay. The only problem is you have to train the patient how to be examined, and you have to train yourself and be trained how to use it. Okay. And it's a bit tricky sometimes because you can get a lot of false negative and false response from the patient if you don't apply it properly. So what I tend to do is I use the back of my hand to start with to feel the skin, okay? Feel the pulses with my hands, look between the toes, use the monofilament, and then do the vibration. And I'm done. Yeah, it takes 1 minute exactly. It's in and out, pulses, monofilament, vibration.
There's a private question come in from a patient, and they're asking, well, they have two-part question. One is there any alternative therapies or alternative procedures that you've seen that works? And B, when would you advise to start, or if it's appropriate to start, occupational therapy or physical therapy? How advanced do they have to be?
I must say I did not understand the question. Okay.
So the first part they're asking, are there any alternative therapies that you've seen evidence of that works?
Yeah, you mean experimental therapies, right?
Yes, alternative experimental. I believe
it's all this negative pressure and whatever, and it's all nonsense. Okay. So far, all these experimental therapies came up with nothing. There's a standard therapy, as Dr. Ahmed mentioned, about using analgesia, anti-epileptic, bit of B12 replacement if needed, a bit of antidepressants, maybe some evidence for alpha-lipoic acid. Apart from this, all these experimental negative pressure and whatever, full oxygen, big oxygen room, this is all kind of waste of time, waste of money. And when it comes to occupational therapy, I mean, that's again, you really have to use physiotherapy, occupational therapy, when it comes to the general mobility of the patient, right? So again, that's a broad spectrum input. We're not going to fit every diabetic neuropathy to occupational therapy because they may not need it, right? They just have to have the pain relief so you can have better quality of life. Certainly, if you amputate it, then you need to be referred for OT and physiotherapy, and maybe for psychologists.
Thank you. Sometimes, I can say one add. Sometimes I do send my patients to physical therapy if they're pre-amputation, they don't yet have the gangrene, but they have a severe neuropathy where their walking is so unstable, where they're a fall risk. I would send them to be assessed for a cane, a walker, or maybe a wheelchair because they could actually injure themselves and hurt themselves further. And that aspect, I think a physiotherapist could actually help. Because again, you're trying to prevent the complications of
it's prevention
secondary. And with that, podiatry. I mean, you have neurology on one hand, endocrinology on the other hand, but then you have what's important and what a lot of people don't talk about is podiatry. Going to a good podiatrist, something as easy as clipping your toenails, people don't think much about it. That's a major cause of injury to your feet, and you can set up yourself for secondary infection and gangrene by just clipping your toenails if you're not careful.
True. We don't have a lot of them in UAE. That's the only problem. We probably need more podiatrists, more trained podiatrists.
Exactly. That's the field that we should invest in as a healthcare community.
Yeah, and it's kind of outpatient shops. They can exist anywhere.
Thank you. A private question is coming in from this patient. They're saying, is it common to experience vertigo and weakness and head dizziness when undergo this? Because they've just started to experience it recently, and they want to get your advice on it.
That's very good. Now, before you accuse diabetes with neuropathy, of course, all these symptoms, vertigo must have the ears checked and make sure it's not, Dr. Ahmed knows better than me, it's not a C-spine or neck spine problem. And most importantly, it's not a lack of blood supply, okay? And it's not atrial fibrillation or irregular heartbeat. It's not anemia. You see how wide it is when you think of medicine, in a practical way. And eventually, yes, autonomic dysfunction, as I talked to you before, it's not just neuropathy, it's not just your feet, it's the whole nervous system. Yes, you may get a bit of dizziness once you have advanced neuropathy, yeah, but that's kind of more of a type 1 patient, an advanced patient where they have neuropathy, gastroparesis, which is a problem with the stomach for the patient if they don't understand this, and maybe a bit of kidney disease. It's very uncommon for vertigo and dizziness to be related to the diabetic neuropathy, but it might exist.
Thank you. Erectile dysfunction. I know we're talking about.
We mentioned this before.
It's pretty common. You see a lot of erectile dysfunction with people with diabetic foot problems, or do you tend to see it even by itself? Or
very good point. Very good point. Actually, you see it before. Not big relation between diabetic foot or foot neuropathy and erectile dysfunction. For some reason, they don't coexist together. What I have noticed is we see the erectile dysfunction before we see the foot problem. Okay. And that's largely because of the microvascular lack of blood supply, obesity, the psychological burden of diabetes, and the number of medication they take, and the alcohol and smoking. So we tend to see erectile dysfunction earlier than what we see diabetic neuropathy in the feet. And you have to ask people, don't tell you about it. And patients who are listening to me, you should not feel embarrassed. We do exist, and we have been educated, and we are blessed to work in UAE, and your government support us quite a lot. You should not be shy of asking anything when you come to the clinic, okay? The time is yours, our time is yours, our service and knowledge has been designed to improve your quality of life. We feel for you, and it's not a taboo to tell your patient, men or women, that you have a sexual problem at all. It's very easy to solve. We can solve it within maybe 3 to 4 weeks.
And I agree with you. أنا دايما بقول للمرضى إنه اللي ساكنين بالإمارات إنه الدولة عم بتقولكم كيف فينا نساعدكم. It's basically telling you, I want to help you. Take advantage of it. يعني use it to your advantage. See a physician. Get treated. There's no reason لواحد عنده سكري or diabetes or any other problem بالإمارات and not seeing a physician to be taken care of. It's actually almost criminal on your part as a patient that you're not taking advantage of the resources.
Yeah, please tell us what you have.
Finally, herbal supplements. I know that we're not talking so much about them, but I know sometimes patients will come and say, I heard that this herb, may help me, or that herb may help me, or my friend recommended I should take, some flowering plant. What do you tell those patients?
Zero. Look, we don't know everything, right? And sometimes things might work for patients. But if you use something that has no evidence and your doctor has no knowledge about it, and the Department of Health has not recommended it, then please don't use it.
I agree. And you could actually have or complications from taking something that's not approved.
I say zero evidence for it, but look, I give them the information I have, okay, and give them. I'm trying to say, look, you have to consent yourself to this. It's nothing to do with me. My knowledge about this is 1, 2, 3.
Excellent. Anything else, Gerard? Or
no, I think this brings the end to the webinar. Before I hand back to Dr. Ossama and Dr. Ahmed to say their final message, I would just like to remind you that this was the second webinar, and we will have, just bear with me, we will have next on the 22nd of September, the final webinar. This is on pain medication, proper use versus misuse. So a very important topic. So please mark your diaries for September 22nd, where the third webinar and the last webinar in this series will take place. I will now hand you back to Dr. Ahmed and Dr. Ossama for the final key messages, take-homes, and then we will end the webinar.
Dr. Ossama? Okay. First of all, I'd like to thank everyone for attending. We had a lot of very interesting questions tonight. The topic was amazing and very educational. I'd like to thank the sponsors, as I had said before, Pfizer Upjohn for sponsoring the event. I'd like to thank Sheikh Shahbouz Medical City for hosting the event, and Gerard from Focus Gold for getting it all together. And finally, the audience and Dr. Ossama for actually taking time today to speak to us. I think when we look at diabetes and diabetic foot complications, it's important to seek treatment. I mean, if you have diabetes, you should be checking out, you should be checking your feet, you should be checking for neuropathies. And if you have a sign of painful neuropathies, you should be talking to your physician for proper treatment. They are available. We have multitude of medications that we can use as physicians to help people live a better life. And I think that's the purpose of these webinars, that we want to raise awareness so that people recognize the problem, so they can see the people that can help them. Dr. Ossama, anything you'd like to add?
Can I just say, honestly, this is the most, I've been giving talks quite a lot over the last 15 years. That's one of the most enjoyable webinars. You know why? I've had these people be in front of me. That's, when you say, Gerard saying the audience, I've had I don't know how many people were listening to us. I'd like to thank them for listening to us. I enjoyed it quite a lot. Look, unfortunately, diabetes will be on the rise, but take advantage of the number of the facts that we're starting to get about diabetes. Take advantage of being in the United Arab Emirates. Feel free to ask your doctors at any time. Do not use an internet website that not recognized. Do not use herbal medicine that you don't know. You are in the best country in the world. You're probably getting one of the best medical services in the world. And believe me, the government of UAE kind of provide a lot for the patient. You may not know how much being spent, and you don't know how much time the government put for you. Take advantage of being in UAE, and we're always here to help. And I would like to thank you, Ahmed, for being the chair of this session, and Gerard, it's been a pleasure to deal with you for the first time. Thank you very much.
Thank you.
It's a pleasure. Thank you.
Thank you, Dr.
Have a lovely evening, all of you.
Thank you, everyone. Good night.
Bye-bye.
Assalamu
Thank you. Assalamu alaikum.
Bye-bye. Good night.
Bye-bye. Good night. Bye-bye.